Okay, we're going to talk about trauma for emergency medicine board review and in training exam review. It's going to be very rapid fire. We're not going to dive into any specific details. We focused on board prep, not necessarily the best clinical practices, and we'll talk fast due to time constraints, and there's obviously a lot of overlap with the orthopedic section. So basics, remember your ATLS, remember ABCDE, remember your secondary survey with a detailed H&P and FAST exam. A couple of facts are two most common causes of death between the ages of 1 and 44 are head injury and hemorrhage. Trauma is the number one killer of those people. Things that CT misses: diaphragmatic injuries, pancreas, basilar skull fractures, and hollow viscous injuries. You have to know your hemorrhage classification. Essentially, class 1 is going to have normal vital signs. Class 2 is going to be tachycardic with a normal blood pressure. If they're hypotensive, you're down in the class 3 range, and class 3 versus class 4 is just how sick do they look, essentially. You have to know GCS, right? You have to be able to do this off the top of your head, both clinically and for your board exam. I always remember I4, verbal 5, motor 6. Okay, let's start with some head trauma. Just some general facts and small pearls here, right? So Cushing's reflex is hypertension, bradycardia, and irregular respirations due to increased intracranial pressure. So they may give you a patient with some vital signs that kind of match that and ask you what's going on following trauma. General management is airway, intubate if necessary, elevate head of bed, avoid hypotension, seizure prophylaxis. Again, this is in head trauma. For concussions, loss of consciousness is not that uncommon. Do not return them to sport until complete resolution or cleared by somebody. For concussions on your ITE, you probably won't get into any detailed questioning there. And then cerebral contusions, you should think deceleration injuries and shaken baby syndrome. So there's decorticate and decerebrate posturing. In the real world, this really doesn't matter a lot, but on your board exam, this is going to help you figure out what your GCS is. And just remember, for decorticate, the arms are flexed towards the chest, and in decerebrate posturing, the elbows are extended to the sides. The oculocephalic reflex, or the doll's eye response, you have to know. Essentially, the response with the eyes moving in the direction opposite of the head turning indicates an intact brainstem. So if you move them to the left and their eyes go to the right, that's a normal reflex. Intracranial hemorrhage table. I'm not going to spend too much time on here. Other than that, you should know a few things, right? Epidural is going to have a convex or lenticular shaped hematoma, and it's going to focus on an arterial bleed, which is why you have a lucid period, then you rapidly decline. Subdural hematoma is going to be crescent shaped and have a slower decline and associated with a venous bleed. All right, skull fractures. You have to know that temporal bone is number one. That makes sense. It's the most, it's the thinnest in certain areas, right? You should know hemotympanum, which is pictured here. Raccoon eyes, also pictured in battle sign. They may show you a picture and ask you a question. You do not put an NG tube in these patients. Pneumocephalus indicates open fracture, just like it does anywhere else in the body. And if you see any CSF rhinorrhea, or they say there's a liquid draining from their nose, you want to see a target lesion on filter paper to prove that that is CSF and not just blood. There are different flavors of herniation. Okay, subfalcine, right under the falx, is the most common, where the frontal lobe goes from right to left or left to right. Uncal herniation is when the temporal lobe herniates down into the cerebellum. These patients will have a blown pupil and ipsilateral hemiparesis. Those are very sick patients. And tonsil herniation, they're less likely to ask about, but that's when the entire brainstem goes through the foramen magnum. Those patients essentially are dead. Lefort fractures, you have to know these. This is a low-hanging fruit for a ITE question or board question. Basically a mid-face fracture resulting in detachment of the maxilla from the skull. And all of the fractures involve the pterygoid plate. Best diagnosed on CT scan, right? So they show these x-rays on the right here, but not really useful in my opinion. So Lefort 1 is just the palate, right? So just think that the sort of the teeth are involved, so to speak. Lefort 2 is now you have the nose, and then a Lefort 3 involves a zygoma, so the orbital floors are involved, right? So it's the teeth, the nose, and the eyes. Mandible fractures, pretty common, not a huge deal in terms of life-threatening stuff, but they may predict other pathology. You're going to figure that out with malocclusion. They're going to be unable to open their mouth, lip paresthesias. The body is most common. CT is probably your imaging modality of choice if available. And obviously, you're going to give them antibiotics with an ENT or OMFS consult. These are open fractures almost by definition. Orbital floor fractures. Think of diplopia, proptosis, limited extraocular motion, decreased visual acuity, infraorbital paresthesias, inhibited upward gaze if the rectus muscle drops down into the maxillary sinus, right? CT orbit is the modality of choice. And you're going to call optho and ENT, decongestants, augmentin. The big thing here, though, is the upward gaze palsy from entrapment of the inferior rectus muscle. Nasal septal hematomas, right? These are dark red masses or hematomas associated with a nasal fracture. You should incise these, right, and pack them to prevent saddle nose deformity and pressure necrosis in the future. Pretty easy to diagnose, actually, you just have to look. Dental avulsions, there's different flavors of this. Essentially, you want to handle the tooth by the crown, not the root, right? So the part that's exposed to food, not the part that's buried in the jaw. Just rinse it, right, and put it back in some type of solution, typically citric acid or fluoride. And for baby teeth, you don't need to reimplant them. If you have Hank's balanced salt solution, that's ideal. Milk can work, as well as saliva and saline. All right, let's get on to some spine and neck pathology, starting with blunt neck trauma. So blunt laryngeal trauma, right? You're going to think neck pain, airway symptoms, which can be in range and spectrum. Awake intubation if possible, because you don't know how bad the airway will be till you get in there, which means don't paralyze them without being ready for a surgical airway. Pharyngoesophageal, so a little bit lower. You're going to have often asymptomatic. You may have the subacute emphysema, so-called Hammond's crunch. They may be vomiting blood or coughing up blood. Chest x-ray may show pneumomediastinum, and you want to treat them with antibiotics. And essentially, they are going to need endoscopy and an esophagram to try to figure out where the lesion is. Blunt cerebrovascular neck injuries, right? So these are blunt carotid injuries, right? Could also be vertebral. They may just have pain in their neck. They may have neurosymptoms. Hard signs that you want to look for on your exam would be an expanding hematoma, bruise, active bleeding, stroke-like symptoms, or airway compromise. Horner syndrome can also be present, and you diagnose this on angiography. And of course, these patients need surgical intervention from vascular and neurosurgery and anticoagulation. Penetrating neck trauma. The boards love to talk about the 3 zones and how you manage them differently. The big thing here, I guess, is zone 3 is above the angle of the mandible. Zone 2 is from the cricoid cartilage to the angle of the mandible. And zone 1 is from the clavicles up to the cricothyroid cartilage, okay? Hard signs of penetrating neck trauma, this is where you say, oh shit, right? Include airway compromise, air bubbling from the wound, shock, severe active bleeding, expanding or pulsatile hematoma, neurological deficit, hematemesis, and massive subacute emphysema. If the platysma is violated, that suggests that the injury or penetration is deeper. For these patients, you want to intubate early if there's any hard signs, okay? And if there are just soft signs, you can probably get away with just angiography and a little bit slower pace of management. All right. For osseous lesions, I might have this in a couple different parts of this lecture, but essentially you should understand that any spinal injury can be considered a 1, 2, or 3 column injury, and that means the anterior, middle, or posterior columns are involved. So the anterior column is the anterior 2/3 of the vertebral body complex, including the anterior longitudinal ligament, etc. The middle column is the posterior 1/3 and the posterior longitudinal ligament, and then the rest of this in blue is the so-called posterior column, right? Which also includes the ligamentum flavum, the interspinous ligaments, facet capsules, supraspinous ligament, etc. So 3 different columns, very important to understand. So C-spine fractures, right? You need to know the Canadian C-spine rules and the nexus criteria. You should pretty much know those by heart. In the clinical world, we see so much trauma that you need to know when to image and not image, essentially, but you have to know those for your boards as well. Classification of C-spine fractures includes flexion fractures, vertical compression fractures, flexion rotation, and then extension fractures, right? Most commonly fractured spinal level is C5, most common subluxation is C5, C6. I'm not going to go over all of these individually, but you certainly need to know them, right? Jefferson bilateral facet dislocation, odontoid, atlantoaxial, hangman's, and teardrop fracture are the unstable fractures. The stable fractures are wedge fracture, transverse process fracture, clay shovelers, unilateral facet, burst fracture, and isolated fractures. And you'll note that the majority of these are all single column fractures, right? The unstable ones are typically 2 or 3 columns. Odontoid fractures, okay, there's type 1, type 2, and type 3. And the type 3 is generally considered the best one because it's the most stable. All right, reading C-spine films, this is an aging art, but still important, right? So typically we're talking about the lateral film where you have the best view. There are other things to learn from the swimmer's view and the PA view and stuff. But on the lateral view, you should see the spinal line and the laminar lines should be smooth and congruent. You should have a normal prevertebral space. The mnemonic is 6 millimeters at C2 and 22 millimeters at C6, which is marked here, okay? In the open mouth view, you can see C1 and C2, and those should align, good for finding an odontoid fracture. Thoracolumbar fractures have a little bit different flavor, okay? Thoracic fractures, much more likely to have a spinal injury, okay? Most commonly, this is the low thorax, upper lumbar. These can be wedge fractures, which are stable, right? Compression of the anterior column, burst fractures with multiple fragments include both the anterior and middle column, right? So it's an intermediate sort of injury pattern. And then a chance fracture is through all 3 columns and associated with lap belt injuries. So chance fracture, 3 columns, unstable, right? Minor fractures that I did not include transverse process, spinous process, and pars interarticularis fractures, okay? All right, so the generally unstable fractures, right? So the wedge compression fracture is a 1 column fracture. That's generally actually stable, which is why it says neurological deficits are uncommon. The others, of course, are 2 or 3 columns and are generally unstable. Okay, chance fracture, unstable, burst fracture, intermediate, flexion, distraction fractures, and translational fractures are both unstable. Spinal cord injuries, okay? Above C5, right, requires intubation because the phrenic nerve and the diaphragm are now involved. You obviously want to immobilize them. They need advanced imaging and neurosurgery or spinal surgery, and just be ready for any hemodynamic instability. Skiwara is kind of a legacy term before MRI, where essentially you knew they had an injury, but X-ray and CT were normal. Central cord syndrome is thought to be the most common form of Skiwara. You should understand the difference between spinal shock and neurogenic shock, right? Spinal shock is a stunned cord as opposed to neurogenic shock, which is not a stunned cord, right? So in the terms of stunning, it's like wherever that injury pattern is, you have loss of spinal cord function below that level, and it's defined as transient and typically returns spontaneously, okay? Of course, at time 0 in the emergency department, you're never going to know that, but in retrospect, you may be able to delineate that. Neurogenic shock is loss of sympathetic flow from thoracolumbar injuries, loss of peripheral vascular resistance, and unopposed vagal tone, right? So they're warm and hypotensive, bradycardic, okay? You have to think about other stuff. Obviously, you start with fluids and then inotropies and atropine. All right, cord injury patterns, okay? So anterior cord syndrome, poor prognosis, hyperflexion injury, right? It makes sense that if you flex the back, you're going to injure the front of the cord. Paralysis, loss of pain and temp, preservation of position, crude touch, vibration. Okay, posterior cord syndrome is much more rare, right? I usually think of this as like tibius dorsalis with a sort of disseminated syphilis infection, but in terms of trauma, loss of 2PV and ataxia with positive Rombergs, but their corticospinal tract is intact, so their motor function is essentially normal. Central cord syndrome is most common with a pretty good prognosis, right? That's an extension injury, typically if they have some canal stenosis, and it's going to affect the upper extremity more than the lower extremity with intact bowel and bladder. Brown-Séquard has a great prognosis as well, hemisection, usually to penetrating trauma as opposed to blunt trauma, and ipsilateral loss of motor and 2PV, and then contralateral pain and temp, right, because they decusate at different levels. And then a complete spinal cord injury, I didn't add anything. That's pretty straightforward, I think. Okay, chest trauma. Pneumothorax, right? Accumulation of air in the pleural space. Trauma is much more common than spontaneous, although both happen. Pleuritic chest pain, shortness of breath, tachycardia, loss of breath sounds. Diagnosed on an upright chest x-ray, although a lateral decubitus is more sensitive and a supine chest x-ray is less sensitive. Ultrasound is better than either of those with absence of lung sliding. And small ones you can treat with oxygen. Obviously, if it's large or polytrauma, you're going to put a chest tube in. Tension pneumothorax is when that air is getting trapped in there. You have mediastinal shift, you have instability, right? Distended neck veins, tracheal deviation, hypotension. It is a clinical diagnosis on your board exam. It's a clinical diagnosis in real life. All right, you're going to needle decompress them on the ipsilateral side, and then you're going to convert that to a chest tube. Open pneumothorax, where the air is not getting trapped, it's just coming in and out, okay? Sucking chest wound with sub-Q emphysema, usually there's air tracking into some of the sub-Q spaces, which is what that blue arrow is showing you. Also a clinical diagnosis with a three-sided dressing, so air can get out but not in. Pneumomediastinum can happen from trauma, but other things like, most classically in my experience would be somebody who does meth or even marijuana can cause it, right? It's usually asymptomatic to chest pain with some sub-Q air. CT is obviously more sensitive, but you got to do an esophageal evaluation as well. Hemothorax, right? Often associated with pneumothorax, decreased breath sounds, dullness to percussion, hypotension. If there's more than 250 mLs, you'll see it on chest x-ray. Obviously, if it's whiteout, you need to consider massive hemothorax with massive transfusion protocol, and you also just want to consider other causes of whiteout, right? So diaphragmatic rupture, lung collapse, pulmonary contusion. Okay. Treat with chest tube, blood products, and surgical intervention if there's massive hemorrhage. Rib fractures are the most common and significant chest injury in adults, with the middle ribs the most commonly injured, and are associated with other pathology, right? High ribs are vascular, low ribs are liver and spleen. Ribs 4 to 9, right? Most common ribs associated with lung contusions. Patients typically have chest wall pain and are point tender on those areas. Chest x-ray is not very useful. CT is the imaging study of choice here. And essentially management is pulmonary toilet. However, if they have a lot of ribs, they probably get admitted. And if they're old or have half their ribs or more, they go to the ICU. Flail chest is defined as a fracture in 2 places in 3 adjacent ribs with paradoxical movement during inspiration and expiration. Diagnosed on chest x-ray or CT, but also clinically if they really have one. And essentially treat it with analgesia and then positive pressure ventilation to reduce the work of breathing. Sternal fractures, okay? Anterior chest pain, pleuritic, they're typically point tender on their sternum. Can be seen on lateral chest x-ray, but much better seen on CT or ultrasound as well. And treat with pain control if an isolated injury. Pulmonary contusion shows hemoptysis, dyspnea, tachypnea, tachycardia, chest wall bruise. Can occur early on, but can also take up to 6 hours to present. Diagnosed on chest x-ray. CT is obviously more sensitive. And if they're sick, you need to intubate them and have a low threshold to admit, because if you're at time 0 or time 30 minutes, there's a high chance that they could get worse before they get better. Remember, this is obviously a lung bruise. We know bruises get worse over time. Myocardial contusion, or better stated, is a blunt cardiac injury, which range in spectrum of pathology. Right ventricle is more anterior, so most commonly affected, but obviously can include valves and coronaries and stuff. Seen in high-speed deceleration injuries where the chest hits the steering wheel. You should think about this when you see unexplained tachycardia or dysrhythmias, though of course, just like pulmonary embolism, sinus tach is the most common. There is no diagnostic gold standard. This is sort of a moving target in the literature, but essentially you want EKG and a trope, and then if you're concerned at all, an echocardiogram should be obtained. And then they need serial POCUS to evaluate for pericardial effusion down the road. Cardiac tamponade, right? So the classic would be Beck's triad. Sorry, that's a typo. Hypotension, JVD, and muffled heart sounds. Note that breath sounds will be present when they're trying to confuse you with attention pneumothorax. Pulsus paradoxus, which is a reduction of blood pressure on inspiration. Ultrasound is your imaging modality of choice. EKG may show low voltage. Start with IV fluids, but obviously if unstable, you've got to get that fluid out of there somehow, right? Traumatic aortic injuries. Okay, there's a lot of chest x-ray findings that may suggest this, but I would say wide mediastinum is going to be your big clue. Most of these patients die before they come to the hospital, and if they make it to the hospital, they typically die there. These patients will have chest and back pain, hypotension, stridor, murmur, SVC syndrome. pseudocoarctation from a periaortic hematoma. CT is better, probably consider TEE as well. You want to beta block them with very careful resuscitation and early involvement of cardiothoracic surgery. Penetrating great vessel injury, right? Massive blood loss, whether this is arterial or venous, these things are going to bleed, right? Unilateral loss of pulse, if it's a subclavian artery diagnosed with angio, and obviously these patients are going to require surgery. Okay, moving on to abdominal trauma. So just some general stuff. Handlebar injury, you're going to think duodenum or pancreas. Okay, seatbelt injury is going to be the transverse abdominal wall contusion with a chance fracture, which we mentioned, the unstable three-part vertebral body fracture or spinal column fracture, and then abdominal visceral trauma, right? Small bowel, spleen, liver, etc. And then retroperitoneal injuries are diagnosed with CT. They are not seen on fast exam. Blunt diaphragmatic injury, right? Frequently missed because the static imaging of CT and X-ray often do not identify them. Think Kerr's sign, right? They're going to have shoulder pain from a diaphragmatic injury, bowel sounds in the chest, okay? Gold standard is laparoscopy or thoracoscopy. NG decompressions, they're going to need surgical repair, of course. They're often missed, they don't heal, often misinterpreted as a pneumothorax or a hemothorax, pulmonary contusion, etc. Right? So one of your board questions might show you all of those pathologies, and you're going to have to be able to distinguish them. Blunt hollow viscous injuries, right? Abdominal tenderness, seatbelt sign, delayed peritoneal signs. Hopefully you would see some free air on the chest x-ray or the CT, and obviously if you see that, laparotomy is indicated, okay? Blunt solid organ injury, right? Spleen is number one, it's more squishy. It's often the only organ involved in blunt trauma. Fast positive, liver number two, and if they're stable, they can be watched. Unstable, needs OR or interventional radiology. Penetrating abdominal injury is going to be the liver over the small bowel, and the reason is liver is the biggest structure, right? So it's the most vulnerable. For GSWs, it's going to be small bowel over colon over liver, and you can evaluate these wounds locally. Don't probe them. CT with PO and rectal contrast can help you evaluate the bowel if there's any uncertainty. And these patients often need to be OBS, even if they have a low post-test probability of an injury. You have to know your FAST exam, okay? This is super important, I think, both in clinical medicine, but also for your ITE and board exam, right? So you need to know your subxiphoid view, your right upper quadrant, your left upper quadrant, and your bladder view. And then you need to know your echocardiogram as well, which is not pictured here, okay? And then your lung sliding, which they have at the bottom here. FAST is positive after 250 mLs of blood, same thing as a chest x-ray for hemothorax. Not sensitive for solid organ or hollow viscous injuries or any retroperitoneal bleeding. Serial exams are helpful, and false positives would be like somebody with liver cirrhosis and ascites, or females who are menstruating can also be positive. DPL, this is a legacy maneuver not typically performed in places that have access to ultrasound, but you should know the criteria for what makes a positive DPL. All right, trauma in pregnancy. Number one cause of non-obstetric maternal death. Makes sense, right? Also number one cause of death in most adults under the age of 45. High incidence of serious abdominal injury, right? Lower incidence of chest and head trauma. Number one fetal injury is skull fracture. The most common etiology is MVC, especially failure or misplacement of the seatbelt. Second most common would be intimate partner violence, okay? Normal vitals in pregnant women include a heart rate that goes up to 110 or 115 and a softer blood pressure. You have to know that. Physiologic hypotension can occur from the uterus sitting on the IVC, so you may have to roll them into lateral decubitus position. Normal fetal heart rate is around 140, 150. Placental abruption includes rupture of membranes, vaginal bleeding, and uterine tenderness. Ultrasound is the imaging modality of choice. KBT tests can evaluate for rupture of membranes and also the need for ROGAM. Tube thoracostomy goes higher in the fourth intercostal space. If you need to put one in, you focus on resuscitating the mother first and consider emergent C-section if viable. Perimortar C-section if cardiac arrest with no ROS within 4 minutes. And then differential diagnosis of serious complications includes placental abruption, maternal fetal hemorrhage, uterine rupture, and preterm labor. Pelvic trauma. Okay, acetabular fractures are seen in young patients with high energy and older patients with low energy, right? So car accident in a young person and a fall down, go boom in an old person. CT is more sensitive for most bony injuries. This is no exception. And this can be considered a complication of a hip dislocation as well. Pelvic avulsion fractures here. I tried to put the muscles that can tug on these areas, right? So number one is the iliac wing. You're going to think about the abdominal muscles. Number two is the superior pubic ramus, sartorius and gracilis. Number three is the inferior pubic ramus, same thing. Four is a transverse sacral fracture. Five is coccyx. Six is the ASIS, which is sartorius and tensor fasciae lata. Seven is a IIS, which is rectus femoris. And eight is ischial tuberosity, which is the hamstring. Major ring fractures, right? And I'm going to have pictures of these, but there's lateral compression, anterior posterior compression, and vertical shear. These patients will have pelvic pain, tenderness, edema, ecchymoses of the perineum or pelvis, Destat sign, which is a hematoma over the inguinal ligament, which I don't think I've ever seen. Diagnosed on AP films, generally speaking, with some special views like the oblique and Judet views. And just like other fracture patterns that we've talked about today, one part can be stable, two parts is by definition unstable. Widening of pubic symphysis requires a pelvic binder, and that goes over the greater trochanter. And rectal and GU exams should generally be performed as well, looking for blood. Okay, lateral compression fracture represents about half. Think about a driver who gets T-boned or a pedestrian hit on their side. The x-ray will show a pubic ramus fracture, sacral compression, or iliac wing fracture. And you can see on the x-ray that the sort of pelvic outlet view is compressed and the left side of the pelvis has been pushed inward. AP compression is about a quarter, so less common. Typically a head-on MVC, and you're looking for disruption of the pubic symphysis and or the SI joint, both of which are seen on this x-ray. And then finally, vertical shear, much less common just because people don't typically fall or jump from height as much as they experience a car accident. This is the most catastrophic, of course. Fragments and symphysis are displaced vertically and associated with more neurovascular injuries. Hip dislocation, posterior is most common, shortened, internally rotated, and adducted. You can see this on x-ray pretty easily. You want to prioritize reduction due to the feared complications of AVN and arthritis, which are very, very real. Okay, GU trauma. Straddle injury is most common, also direct blow, penile fracture, often associated with significant pelvic fractures and shearing forces to the bladder or urethra. More common in men. There's often blenthomiatus, trouble voiding. There could be vaginal bleeding, perineal hematoma, high-riding prostate if you think it's a posterior injury. Retrograde urethrogram is useful to identify the injury pattern and should be done prior to placing a Foley catheter. Partial lax may heal with good catheter placement. Otherwise, surgery probably needs to happen with urology. Bladder trauma, right? You can have a contusion, which is just a hematoma causing a change in the shape and shift of the bladder superiorly. That's ideal. Contusions don't require surgery. Extraperitoneal rupture, bladder neck, no communication to the peritoneum. And then intraperitoneal rupture, which is distended bladder at the dome, and the contrast leaks into the peritoneum, or the urine leaks into the peritoneum. That's what's pictured here, okay? Pain, tenderness, hematuria, trouble voiding, peritonitis, diagnosed with a rug, with a clamped Foley, and if it's intraperitoneal, the contrast will leak into the cul-de-sac, right? And of course, if it's intraperitoneal surgery, you can consider Foley catheter for the extraperitoneal, but of course that decision is made with urology. Ureter trauma, okay. Penetrating trauma, iatrogenic during surgery is probably more common. Signs and symptoms are hematuria and flank pain, diagnosed with a pyelogram, and these always need to be repaired. Renal trauma can be graded like other blunt trauma in the liver and spleen, okay, so 1 to 5. Flank, bruising, CVA tenderness, hematuria, diagnosed on a CT scan. If they're sick, they need interventional radiology or OR. Ureteral injuries require surgery as well. A lot of the smaller hematomas may be observed, or lax may be observed. Okay, penile injuries, spectrum of pathology from a lactation to a amputation, right? Fractures, most common rupture, fractures are a traumatic rupture of the corpus cavernosum, typically during intercourse, so different mechanism. Hematoma evacuation, repair of the tunica. Testicular injuries can be a hematoma, contusion, laceration, fracture, dislocation. You may see the word evisceration, right? Bruising, swelling, and absent testes. Ultrasound can help determine severity of injury. And obviously anything that's open, it's going to require intervention. Some soft tissue trauma. So acute compartment syndrome, right, essentially is characterized by the pressure in the compartment exceeds the perfusion pressure and you get tissue ischemia, most commonly seen in tibial shaft fractures in adults and both bone forearm fractures in children. Most common location is the anterior compartment of the leg, right? So they will have some loss of dorsiflexion or drop foot, right? Pain out of proportion to exam is going to be the biggest thing, okay? You should also think about that with mesenteric ischemia and neck fascia are things that have pain out of proportion to exam on your ITE. The diagnosis is clinical, but you need to know the 6Ps, right? Surgical consult and fasciotomy are a treatment of choice. Peripheral vascular injuries, right? The types are complete transection, incomplete injury with subsequent thrombosis, spasm, fistula, and pseudoaneurysm, so quite a variety. Hard signs are similar to the hard signs of the neck, right? Pulsatile bleed, bruit, thrill, expanding hematoma, obvious occlusion, hypothermia. Soft signs in the emergency department, direct pressure, tourniquet, permissive hypotension, and then to the OR for hard signs, and then soft signs again, if stable, you can get imaging. Finger amputation, right, can tolerate up to 24 hours of cold ischemia at 4 degrees. You want to rinse them with sterile saline, wrap them in saline gauze, right? Put the gauze in a plastic bag and then put the plastic bag on ice. High pressure injuries, right? Injection of some type of fluid, typically grease or paint, that extends down tissue planes, causes inflammation, vascular compromise, tissue necrosis. Often very benign and misleading, as in the case of this picture, that is very innocuous appearing. They might have some pain at the injection site, but this is generally considered a surgical emergency. We want to give them antibiotics and tetanus, splint it, and then call orthopedic surgery or hand surgery, and do not block the digit. Let's talk about burns. Okay, thermal burns. Evaluate the airway, consider other pathology, right? Carbon monoxide and cyanide. Estimate the total body surface area, determine the depth, evaluate critical organs, and for circumferential burns. There's a rule here for total body surface area that you need to know, which is basically 9 for upper extremity, 18 for lower extremity, 18 for front, and 18 for back of torso, 9 for the head, and 1 for the perineum. You want to treat them with oxygen, intubate early if any airway concerns. You want to have urine output hitting 1 or 2 mLs per kg per hour, right? We've basically ditched the Parkland formula. Circumferential burns, consider escharotomy, right? Chemical burns, for acid, you get coagulative necrosis. For alkali, you get liquefactive necrosis, which is worse. Here's a bunch of toxic burn pathology. I'm not going to spend too much time on here. I will say for hydrofluoric acid, right, the treatment is topical calcium. That's one that the boards like to ask about. For this slide, more toxic stuff. For any of the lyes, ammonia, any of the basic stuff, right, remember that the ingestion can cause airway and esophageal trauma. Those ones are a big deal.